Okay, chapter 28 deals with hematologic renal emergencies. We will touch on the hematologic system, the renal system, as we always do when we start chapters. The hematologic system, the blood, kind of represents its own organ system, does have specific functions. We have touched on this quite a bit during class already, so this is nothing new for you guys. We know it clots, it has clotting factor, it controls our bleeding. Delivers that, does that oxygen, carbon dioxide to and from cells, and then also removes, delivers other waste products to organs that can filtrate and remove them. Made up of 4 components, red blood cells, white blood cells, platelets, and it is suspended in plasma. We do know that there are some of our patients that take medications that can affect some components of the blood. So aggregation of platelets, blood, or a fancy term for clotting, is the body's most rapid and initial response to stop the bleed. That's a natural effect. The body's going to try to stop any bleed. Clotting factors are a group of proteins produced in the liver and released into the bloodstream. So if they have any liver issues, that's definitely going to affect their ability to clot. Clotting factors form clots through clotting cascades. So coagulopathies, a study on here, the abnormal clotting of blood. So it can occur, if our body forms these clots too quickly, or on the other end of the spectrum, they clot too slowly. And as I said before, certain diseases make these patients more prone to poor clotting. So, since the liver is that, like I just discussed, advanced liver disease is certainly going to affect that, hemophilia and von Willebrand disease. So identifying these patients. Some of this is going to be, you're going to need to be a little detective. I would be asking our elderly patients, are you on any blood thinners? Okay. Because they are more prone to have life-threat bleeds when that blood is thinned. In comparison to the other patients. So we want to make sure, especially in falls, any traumas with our elderly population, that's a very important piece of information that we do need to find out and relate to the emergency department. So take your standard precautions, always do your primary assessment, your ABCs, care for your life threats, treat those. And getting that history from the patient is really important. Okay, what specific medication are they on? Or do you know what you're on that medication for? Notify your hospital as early as you can that, a standard fall is going to be different than a standard fall with an elderly person who's on a blood thinner. We're always concerned about bleeding we don't see. So monitor the patient, treat for shock, which you all know how to do. You know how to administer supplemental oxygen, keep that airway patent, and transport to the appropriate facility. So anemia is the lack of the normal amount of red blood cells in circulation. So acute anemia, that fast onset, could be from sudden blood loss, as in a trauma. Chronic anemia, patients that have heavy menstrual periods, they may have a slow GI bleed that's gone undetected, or they can't find it. And then they have, anybody that has diseases affecting bone marrow or that structure of hemoglobin. So sickle cell anemia, this being one of them, it is a genetic disease that affects the red blood cells, most commonly in patients of African descent. So as you can see, our happy rubber inner tubey type red blood cell that looks normal, and then the defective, the sickle cell blood cell, looks like kind of a crescent moon shape, very sticky. It's going to have a short lifespan, leading to anemia because of the lack of the red blood cells. Complications we've seen with these patients, destruction of the spleen, chest syndrome, acute chest syndrome, priapism, stroke, jaundice. So, these patients here, unless we're told that, it's going to be really hard to detect, right? So 1 in 13 African Americans has that trait, and having the trait doesn't always mean that they're going to have complications, but you do need to make sure that that's noted. Once again, our favorite 2 words, supportive care, high flow, make sure that you're taking care of your primary assessment, watch for signs of shock, hypoperfusion. And if you have a stroke that's suspected, make sure that your stroke center facility, you have an appropriate place that you're taking them to, appropriate destination. Okay, the renal system components, we've got kidneys, ureters, and urethra. The kidneys are essential for life. They filter, they're the filters. Waste, they remove certain waste, excessive salt that we don't need, excessive fluid, they maintain that fluid balance. So kidneys are very important. Diseases of the renal system affect a lot. So if we've got somebody on board that is end-stage renal failure, takes dialysis, it's going to cause some issues for all over the body. UTIs is one of the more common ones, urinary tract infection. Bacteria usually remains in the area of the bladder. It is painful, hurts when they pee. Really common in our elderly population that aren't as ambulatory and they don't drink the fluid intake level they should. So, but if it's pretty treatable, of course, with antibiotics, but if it's left untreated, it can go up the ureter into the kidneys and they can get a kidney infection, a little bit more serious. Kidney stones made of that calcium formed within the kidney. When they're in the kidney, they're not usually the problem. The problem comes when they are dislodged and they are, they get stuck in the ureter and cause some pretty nasty flank pain. Catheters, your patients with catheters, the biggest thing with catheters is the susceptibility for infection. These patients, they either have a neurologic disorder or they've got some sort of like the prostate cancer that's impeding that bladder outflow. So UTI, like I said, local trauma at that site is the most common. All right, your patients with renal failure, the kidneys lose their ability to filter and remove the toxins, and we have to have that. We have to have that, or of course we're going to get too toxic, acidic, and we're going to die. So acute failure, so shock, toxic ingestion, chronic failures could be inherited, could be secondary to another disease factor. So hypertension, uncontrolled diabetes. End-stage renal disease is irreversible renal failure, all right? So when this patient gets to this point, they have to go to dialysis. So hemodialysis or peritoneal dialysis, 90% are in specialized centers. These patients, a lot of dialysis patients around here, huh? Looks like more than 450,000. So they have to go quite often. So 3 treatments a week, 3 to 4 hours. So if you have a patient that misses a dialysis appointment, it can be pretty serious. So they do often rely on us to transport to and from dialysis. That's going to be kind of common. We do it a lot, of course, at Mayo across town there. So hemodialysis, the patient's connected to a dialysis machine. It pumps blood through filters. There's 2 catheters, and they create that circuit. So the blood is removed from the body, filtered, and returned over several hours. So there's your 2 ports on this patient's arm. Blood is removed on one port, coming out, going through the filtering system, and then re-entering the body. So how do they access this? This one right here is a 2-port catheter. So there's 2 sites. There's also an AV fistula. So if you see any of this, please do not take blood pressures on that side. Somebody worked hard to establish those. There's your 2-port catheter. We don't play with those at all. We don't use those at all. And if you can take the pressures on the other arm, it's better. There's your fistula. Surgical implant connecting that artery and vein. Peritoneal dialysis, talking about the peritoneal cavity, that large belly surface area. They get fluid infused into the abdominal cavity. It's left in there for several hours to absorb whatever should not be in there, getting rid of excess fluid, and then the fluid is removed. So continuous ambulatory peritoneal dialysis, CAPD, the gravity exchange, they do this several times a day. You might be transporting a patient from home with some complications. Continuous cycler-assisted peritoneal dialysis, the machine fills and empties the abdominal cavity while the person sleeps. So if you see something like this that's coming out of their stomach, that you can absolutely ask too, by the way, because this is different than what we're used to. You can ask what that's for, but just kind of pretty much inspect the site. If you see a possible infection, there's not much we can really do about that other than reporting it to the emergency department. So a couple different emergencies, all right, for end-stage renal failure. Those that arise from all of a sudden the kidneys fail, and those that are an offshoot of dialysis treatments. So you do have a really sick patient here. They're not only dealing with this, they're dealing with what's diabetic, whether it's hypertension. So like I said, it usually relates to the fact that they missed a dialysis appointment, and this is causing the issue. So they might be presenting with shortness of breath. Check for that edema, check for that swelling in the lower extremities. Check for electrolyte disturbances, or not check for, but they could possibly have that. And that's like something we're not going to know, but you definitely can see shortness of breath and edema. So if they've missed dialysis, try to find out when the last time was that they attended dialysis. Get your ABCs, supportive care. If you see fluid retention and they're short of breath, consider your CPAP. If you're hearing fluid in the lungs, you're not getting very good results with your oxygen. You guys all know how to use that CPAP. Bleeding from the fistula site or the port sites, clotting, loss of function, numbness, swelling, could be infection at the catheter site. Control your bleeds. Do your ABCs like you always do. Control your bleeds, direct pressure. You might have to use a tourniquet if it's bleeding that profusely, and high flow oxygen, treat for shock. And if they do have like a fluid bag or anything like that, take it with you so the lab can see it. Kidneys are the most common transplant. They do have a special class of drugs that keep those working. And they are increased to infection. So once again, kidney transplant patients, we're going to be able to, at our level, we're going to be able to do supportive care, ABCs. If it's serious enough and if this patient is sick enough, absolutely get an ALS unit started so we can start fluids, and really all of these for the renal function infections. If they are very, really sick, we can certainly start that, those fluid process intakes for those patients. So, and that's pretty much it for this chapter, really short chapter on blood and